task is to talk about interventions in heart failure. The key predictors of favorable outcomes have always been towards assessment of etiology of heart failure, careful clinical assessment, imaging, heart team involvement, and honest counseling and consenting on outcomes so that the patient is able to make an informed decision, and attention to detail because they are all sick patients and the chance of complication and ability to tolerate any complication is very, very low. Etiology-based treatments, coronary artery disease, revascularization, multivessel, PCI is the way forward in very sick patients. Electrical dysfunction, sometimes it's an electrical problem, tachycardia induced cardiomyopathy, where ablation offers definite treatment and fantastic outcomes. If it's a dyssynchrony, you can resynchronize with LBB, which Dr. Dahl spoke in detail. Valvular heart disease, we will talk about that in a second, and then pump support, which I'm sure Dr. KRB went through in detail, and palliative care. So management strategy, I guess the first and foremost is identifying the cause, because unless the cause is identified, the treatment becomes less fruitful. Medical management, of course, tablets and injections, which I won't go into today. Etiological management, this is what we're going to talk about today, is predominantly on interventions based on etiology. And radical management, of course, LVAD and transplant I won't talk into, which you have all seen in detail. What are the practical problems in heart failure patients? They're often sick. Treatment requires open chest procedures, and it's already an insult doing any radical treatment, but when patients are sick with heart failure, other than radical treatments, other like transplant or ECMO, any other intervention is likely to increase the insult to the heart. And more importantly, any treatment has to be aimed at improving quality of life. There's no point in having a successful surgery, but the patient is bed bound or not doing much. They might as well not do anything in the first instance. The whole idea of any treatment is to make their quality of life better than what it was before, and that has to be borne in mind, with minimal invasion, early recovery, and more attention to quality of life by the end of the treatment. Ischemic heart disease, I'll show you a few examples. This is a young man with a triple vessel disease who had a CTO. My pointer's not working very well. So you can see here that the right is occluded, the circumflex has severe disease here, a moderate disease there, LAD just a discrete lesion here. Of course, CABG is an option, but he underwent OCT, got an intervention to all three. The CTO gets opened. OCT of the proximal circ revealed a fairly large MLA, so nothing was done. The OM was stented, the LAD was stented, but this allows return to normal quality of life in 2 days. I think the CABG, of course, is an option, but if a treatment can be offered with least invasion and obtain the same outcomes with image-based angioplasty, they're likely to achieve better outcomes and improve quality of life. This is a patient again with a complex coronary lesion. You have a CTO, and in the CTO, just before the CTO segment, you also have severe bifurcation. So the task will be to open the CTO of this dominant circ and also address the bifurcation. CABG is an option, but if one can achieve interventional management with the least invasion, return to quality of life is literally 2 days. Most patients get back to work in 2-3 days' time. So this is just the CTO. I won't go into the procedure, but I will just show you the fluoroscopic outcome. You can see here the CTO is very nicely open into a very large dominant left circumflex. The obtuse marginal is also fixed with bifurcational stenting, and this is all 2 years before. This is another view of the same patient. And all these interventions, almost all, 100%, are all image-based. We don't do any angiogram-based, because the only way one is going to get the best outcomes is use the best technology, and the best technology by far proven to get the best outcomes in angioplasty is image-based angioplasty. So we use ultrasound in all angioplasties or OCT. This is a young lady with heart failure due to tachyarthros. You can see severe left mainstem stenosis. OCT was tried initially, but OCT rarely gets very good images, so quickly we shifted to IVUS, and this is the post. You can see here left main widely open, and this is the IVUS of the stent procedure, which I will just drag in the interest of time. So this is a patient with calcification. Not all calcified lesions need rotablation, because if you see here, there is calcium circumferential, but the diameter is nearly 2.5. There's no reason to do a rotablation here. So this patient just underwent straightforward angioplasty, and with the stents parked within the calcium, you can see here, these are all stent struts within the calcium, and they achieve similar outcomes as rotablation. And this is all only possible because they're all image guided. Otherwise this patient may have ended up in a rotablation, which would do nothing useful to his coronary. This is a patient with left main. Almost most left mains now can be dealt with angioplasty by specific techniques. This patient underwent an IVUS based angioplasty to his left main. You can see here pre and post, and this lesion here in the circumflex had a pressure wire assessment, and there was no pressure drop, and therefore all of the lesions was left alone, and just this fixed his heart failure. This is a patient with severe coronary disease. You can see here left mainstem disease, diffuse circ, and LAD disease. Again, this patient had a temporary hemodynamic support with a balloon pump. You can see here, and a nice pleasing result of left main angioplasty, achieving a very good outcome. This is a patient again with the two vessel disease. You can see here severe right and a modest LAD, which we don't know whether this is important or not. So we quickly fix the right with angioplasty, and for the left we do an IVUS as always. And you can see here, this is the IVUS from the diseased segment. So it is not really disease, it is just a negatively remodeled vessel. The vessel itself is smaller, it just looks small, so therefore there's no reason to stent, and this was left alone. And this is a patient with a CTO of the LAD. The LAD was completely occluded. This is just from the right, showing a little bit of filling from the left. And this patient underwent a retrograde angioplasty to the occluded LAD. You can see here the LAD is flush occlusion. There is no way we can go antegrade because we don't know where to go. So the best way will be to go retrograde. And you can see here two guides. This is the two guides from the right going on to the left, and now everything is connected. And now, because we have a through and through wire, we can fix everything now antegrade. And this is the antegrade angioplasty after we have a through and through wire, and this is the outcome. This is the pre and this is the post. Very pleasing result from retrograde angioplasty. So this is the pre and this is the post. Very nice result. This is also 2-year outcome. This is another patient which also had multivessel. I won't go into this in detail. We'll move on. What about electrical dysfunction? I think tachycardia induced cardiomyopathy. I think Professor Joy Thomas is going to talk about this later. But the best outcomes in tachycardia induced cardiomyopathy are achieved with definite treatment, with being ablation. This is just 3D maps of a patient who had tachycardia-induced cardiomyopathy due to atrial fibrillation. He had pulmonary vein isolation with 3D navigation, and that resulted in very good outcomes, and his heart failure completely resolved. Usually they go back to normal LV function once the tachycardia is addressed. CRT, I won't go into this. This has been discussed in detail, so we will move on. What about patients in non-tertiary centers? Not all centers may have heart failure expertise or ability to step up in decompensating patients. This is a patient we got referred, 65-year-old auditor, LVEF of 15%, severe aortic stenosis, and was having cardiac arrest. So in patients in a non-tertiary center where there is no cardiothoracic support, no aggressive means of initiating cardiothoracic anesthesia, sometimes it can be very difficult because the patient is too sick to be transferred. So this is the log of events. So we had a call at about 7 a.m. At our office. By 7:10 the hospital facilities were all assessed, and the patient details were gathered by 7:30 a.m. By 7:40 we left with 2 blue light ambulances, and we retrieved the patient by 7:55. So what did we do when we went to the hospital? The patient had severe LV dysfunction, cardiac arrest, aortic stenosis. Any CPR we do now is not going to generate any cardiac output because there's aortic stenosis. We cannot shift the patient safely. So this is all without GA. There was no anesthetic support there. So this is just with echo support. We went on percutaneous ECMO, connected the patient to a VA ECMO, and the circuit was established. Once the circuit was established, then the patient has a parallel circulation. The patient is safe. Now the patient can be shifted. So we shifted the patient across the city from a non-tertiary center into a tertiary center, where we were able to fix the aortic stenosis with the TAVI, then fix the triple vessel disease with bypass, and the patient was discharged after 12 days in hospital. And this is 2 years down the line. He's a practicing auditor. Valvular interventions. This is a patient who had a TAVI in another center, but a few weeks down the line the patient developed significant heart failure. So clearly the patient underwent TAVI in the first instance because he was high risk for surgery, and when we assessed the patient, it was very clear the patient was having valvular severe regurgitation. This is a problem because the patient had a bicuspid valve. The valve was oversized, and therefore the valve funneled into the LV, and therefore the patient, you can see here significant deformation of the TAVI stent, you can see here, and because the leaflets were not coapting well, the patient was having valvular regurgitation. Now this is a very difficult scenario because the patient has a TAVI. What do you do? Putting another TAVI is not going to take off this valve which is already deep diving into the LV. Sometimes we just have to do this. So we just snare the TAVI valve with 2 snares, one from the left and one from the right, and once you have both snared together, essentially the idea is to pull it out. There is nothing scientific about it. You just pull and hope it ends up in the right position, but often it may not, and the valve comes out, and then you have to snare the whole valve out somewhere in a safe position to the descending aorta. And here we are pulling the valve out in this very sick patient, and the valve was eventually pulled out across the aorta because the valve went out of the valve, and the valve was parked somewhere in the descending aorta, and then through the valve we put another TAVI, a downsized TAVI in the right position, and you can see here the new valve is being traversed through the old valve which is parked somewhere in the celiac axis. And this was the new valve implanted, and this is the new position, fairly high, and no regurgitation. This is in 2016, and the patient is doing very well, and he continues to have the second TAVI in the abdomen which does not cause any problem. And this is the patient who was published. This is a very extreme patient, severe LV dysfunction, EF of about 15%. You would all agree in 2 views. Severe conduction abnormality also, you can see here on the ECG, and he had a bicuspid aortic valve. This patient is invariably going to end up in a pacemaker, invariably is going to have a cardiac arrest when we do rapid pace, and therefore we have to be prepared. So this patient, we put a CRT beforehand because we know it's going to end up in complete heart block, and because the bicuspid valve, we put on an ECMO. Everything is done percutaneously. We do an upfront ECMO, a venous cannula, and an arterial cannula. Once the arterial cannula, venous cannula is all ready, then we do rapid pacing and implant the valve and post-dilate. Now, because we have an ECMO support, there is no risk of cardiac arrest. Even if it does happen, you have a parallel circuit, and the ECMO is then weaned off on the table after 3 hours. Once the TOE shows, the LV started to contract, and the patient got discharged after 6 days, and the patient is doing very well now. This is 2.5 years down. You can see here remarkable improvement in the LV, and the patient is doing very well. This was in fact one of our country's first ECMO assisted TAVI who also had a CRT performed. This is a lady who had severe heart failure due to tricuspid bioprosthetic dysfunction. You can see here baseline, the tricuspid bioprosthetic valve was dysfunctional. Through an iatrogenic ASD, the shunt is from right to left. This says a lot about the hemodynamics. Clearly the right atrial pressure is very high. This is a 3D 4D live 4D TOE assessing the valve. This is from the septum. You can see the intraatrial septum, RA and LA from the top, and through percutaneous means this patient had a valve-in valve through a transjugular approach to try and alleviate her heart failure from a tricuspid regurgitation, and as soon as the valve was done, you can see here, this is the new valve here, functioning normally, no leaks, and straight away the jet reverses from left to right, proving that the hemodynamics have now been reversed, and this patient was indeed one of our country's first tricuspid valve-in-valve. What about mitral? This is a patient who had severe mitral prosthetic dysfunction in heart failure, where surgical means proved high risk. So this patient had a transapical puncture as a hybrid procedure and had a mitral valve-in-valve procedure, and the puncture was fixed with a purse string suture. You can see here, I'm just forwarding it in the interest of time, but essentially a transapical implant, and this patient was done in 2017, so it's just over a year, but indeed was our country's first mitral valve-in-valve, who is doing very well. This is 1 year down the line. This is a patient with severe mitral annular calcification. He is a doctor himself, where the patient could not have a mitral valve replacement, because you can see here on live 4D TOE the amount of calcium. There's no way you could do an MVR. You may, but it's going to be a high risk MVR to get sutures down. So this patient is left with no other options. So this patient had a mitral valve implantation inside mitral annular calcification, which is referred to as MAC, again a transapical approach, and the patient had a successful procedure, absolutely no leaks. The pulmonary pressure from the Schwann came down right away. The patient was extubated the next day, but about 10 days later the patient had infection of peritonitis, and we lost the patient. But just goes to show the possibility that transcatheter mitral valve replacement can be performed in mitral annular calcification. This is not always the case. We don't have to go transapically. Most mitral valves we do through a transeptal transvenous approach, where the patients can go home in 2 days' time, which is the best approach for patients with heart failure. This is a patient who had one just a few weeks back. What about heart failure and severe tricuspid regurg? We all have these patients, previous mitral replacements, aortic replacement, get recurrent admissions with heart failure because they all have severe TR, and there is no percutaneous solution for severe TR. But now we do have a solution, which is they have a CT analysis, and once that is done, this is the right atrial pressures. You can see here severe tricuspid regurg. They have a bicaval system. This is a valve in the SVC, a valve in the IVC. Basically, it's heterotropic tricuspid valve replacement, where we move the valve from the tricuspid position into the caval system, thereby ventricularizing the whole atrial compartment. But the hemodynamic effects are still achieved. And this is one of the procedures we did, is one of the country's first bicaval system. You can see a valve in the SVC and IVC, and straight away the right atrial pressure, you can see here pullback. This is in the right atrium. Now once you pull down the valve, the pressures come down remarkably. The patient is still doing very well. This is performed in May this year with Dr. Prashant and Dr. R.K. Jain in Hyderabad. Sometimes you may also face these patients where the aortic valve prosthesis is a bit small. Large patients, when they're fitted with a smaller valve, for whatever reason, they end up in valve dysfunction and the valve is too small. So this patient had a 19 millimeter perimount. A 19 millimeter perimount valve in the aortic position is going to give you an inner diameter of 17. This is very small for the aortic position. The patient was in heart failure because of severe valvular dysfunction. Now redo surgery was deemed very high risk. If we do a valve-in-valve into a 17 millimeter valve, we are going to make that valve even smaller, even though we may have a normal valve function. So that is prosthetic mismatch for the patient. They will end up in heart failure again. So what do we do about it? We basically do a CT, we measure the valve, we know what is the valve, we actually crack the bioprosthetic valve with a high pressure balloon by rapid pacing. So here we are actually cracking the balloon, the bioprosthetic valve, basically fracturing the stent struts. Once we fracture it, then we put a new valve, and then that achieves no gradient. And this is has been shown worldwide, and this was the first case done in our country successfully. And you can see here very, very pleasing result, a valve into a 17 millimeter bioprosthesis after stent fracture, achieving absolutely zero gradient. A very good option for a patient. Palliative intervention, very quickly, when there is absolutely no option and heart failure, where a transplant may not be an option, they could have a palliative septostomy. Previously we used to just balloon, now we can put an ASD device where you have shunting of blood from the left atrium into the right, thereby offloading the patient temporarily. There is a clinical trial going on, so we don't know the long-term results, but short-term, some selected patients who don't have horrendous pulmonary hypertension seem to do well. Mechanical support, I think what we have realized is drugs are bad beyond a certain point. They generate lactemia and vasoplegia. Early pump support seems to be a good option. IABP is great, but if you have a blood pressure, if you have no blood pressure, there's nothing to augment, and therefore IABP may not be a good option. Of course, a lot of technologies are there, but what's available in India and practical in India that we have seen and which is cost effective is ECMO, because it doesn't cost too much and it gives complete lung and cardiac support, with which we have been doing multivessel PCIs, epicardial VTs and TAVR successfully, and that seems to be cost effective for our country. I shall stop there. Thanks.